The next session is President Lecture. This session will be chaired by Dr. Masao Omata. Dr. Omata, please.
Yes. Excuse me. The presidential lecture will be given by the chairman of this meeting, the Professor Ueno, and the title is In Search of the Silver Bullet for Hepatocellular Carcinoma. Let me briefly introduce him. He graduated medical school, Tohoku University in 1987, and then goes through the graduate school of medicine 1991. Maybe that was the time I met him for the first time. Then he went to the United States. Professor LaRusso, is that right?
Yes, that's correct.
Yes, he spent Mayo Clinic for 1992 to 1994. Then became Associate Professor of Internal Medicine at Tohoku University Graduate School of Medicine. Currently, he is a Professor and Chairman of Gastroenterology, Yamagata University Faculty of Medicine from 2011 to up to now. And also he is having a position of the Dean of the Medical School since 2020. And he has many awards, but he is much more interested in immunology in areas of the, I think, biliary at the beginning. But today, I am expecting what kind of the spread of his interest in under the title of Search of the Silver Bullet. So, Professor Ueno, please.
Thank you, Professor Omata. It's a very great honor to have a talk here. And my talk title is the In Search of the Silver Bullet for the Treatment of Hepatocellular Carcinoma. This is a photograph of Marcel Proust. That's my favorite writers, as I told at the opening remarks. And this is a representative historical data of the improvement of treatment with HCC. And this is relatively published in recent years. And we hepatologists and maybe oncologists are doing better from the middle of the 1980s to 21st decades. The survival is increasing. And similar reports are elsewhere. So overall, we are doing better. But, and some people say, since the HBV and HCVs prevalence are both decreasing here in Japan, and we hepatitis no longer needed, but it's not correct. This is an example. This is published in, presented at the EASL meeting, and this is the trends of the HBV-related hepatocellular carcinoma. So HCC is expected to increase almost 34% from next 10 years. So even HBV-related HCC is global health threat. This is similar to HCV. HCV in Japan and maybe in Egypt, I think the prevalence and mobility is decreasing, but in a global standard point of view, incidence of HCC is expected to increase, almost 3% increase, and mobility is maybe increase, estimated increase. So both even viral related HCC is global, great threat to human health. So this is summary. So we have more and more, even in the US, the HCC is increasing and HCC-related death is increasing. So it's a great theme for us, for hepatologists. And 5-year survival is still low in global sense, only 20 to 22%. So we are improving, but it's not satisfactory yet. So we need some silver bullet, magic bullet, or a game changer for treating HCCs. We know it's a game changer or a silver bullet. This is a representative outcome of DA treatment. Now, since we are almost cure all the HCV infectants, we don't need to measure genotype or viral load anymore for daily practice. So it's improving. So the final goal is we need to reach this kind of standard of care. But this kind of to change our circumstances with CC treatment. This is our university data, and my previous chairman, Professor Kawata's age, SCV is surely dominating, and then decreasing these percentages. Instead, alcohol-related HCCs increase dramatically as well as NASH. So silver bullet game changer, we have this: viral hepatitis, NUCs, and CVDAs. Then what is the silver bullet for HCC? This is our beginning point. Then what we have to combat with HCC? Well, from the 1980s, we have surgery, we have interventional therapies such as TACE or TAE, and then beginning of 21st centuries, we have sorafenib, as you well know. And this kind of introduction changed our practice guidelines. And from this entire morning, we are talking about this kind of systemic treatment and some surgical treatment and operations. And this is Japanese guideline. We have similar situations. And this is still study is not finally concluded, but preliminary middle point analysis. This is a famous sub-trial conducted by Japanese hepatologists and surgeons, and surgery versus local regional therapy, RFA. So this is presented by Professor Yamashita at last year's ASCO, and in randomized, non-randomized cohort study, there was no significant overall survival or disease-free survival between surgery or RFA. So with this study, we learned that the good hands surgeons, good hands RFA practitioner like Professor Shina, they are equivalent. But they're equivalent, but they are not cure all the patients with HCC. And this is latest NCCN guidelines. It is similar to our society's guidelines. There are so many known risk factors, and we have actually decreased the hepatitis B and C, but we have more alcoholic and more NAFLD related, and maybe we have some cholangiocarcinoma increasing in some regions. And as a first line, as we talked about the immune combos this morning, there are two immune combo first line treatment options. And this is the most famous one in BRAVE studies. And you know this very well. We have increased overall survival, but even with the sorafenib, we are doing better than the initiation of sorafenib usage at 208. This is another first line regimen for Himalaya protocol. We have better survival, and that's the reason we recommended to use this kind of immune combo as a first line treatment. But still we are doing, there are improvement, but we cannot, it's far from the giving cure for all the HCC patients with this kind of drug therapy only. But this kind of introduction changed our daily practices. This is our treatment options, change of treatment option in Yamagata University, and at the middle of 21st decade, TACE was very dominant, but the number of TACE is now decreasing. We are now doing TACE only with a combination or with some TK inhibitors or some kind of radiation therapies. I'm talking about later. And first-line treatment are immune combos. Actually, disease control rate is around 90%. This is comparatively good, but we don't have any CR only with these protocols. Supposedly we have increased number of CR, maybe 3 or 5% or something, but in real world data, we don't have any CR only with these protocols. And this is other molecules, lembachine. You well know that lembachine is equivalent for sorafenib. And yes, and so there are several other TK inhibitors. All of the TK inhibitors provide us a prolonged overall survival. So that's good for our patients and good for us too, but we cannot give complete cure for these patients. And so we are in seek of, our university seek another bullet. And last year, we have opened this carbon ion irradiation center last October. It's built by Toshiba Energy, and the most characteristic feature is our system is we have rotating gantry. So we are able to irradiate 360 degrees at whichever lines we want. That contrasts to the traditional radiation therapy. It's a horizontal or maybe vertical only. So this our facility is the 7th in Japanese carbon irradiation system. But this kind of carbon irradiation system is now spreading globally. Because Yamagata model is exported to some Yonsei University at Korea and as Busan as well. And Mayo Clinic are now introducing new carbon beam irradiation system and other places. That the carbon irradiation system is one of the Japanese remaining strengths. And in the global side, only one remaining constructor is mainland China. And since the introduction of the rotating gantries, we have more patients with GI and pancreatic and liver patients. Before introducing rotating gantry, more than 95% are only prostatic cancer patients. But now, about 20% are liver cancers. And this is a previous report of this carbon ions irradiation systems. So disease control rate is around 90% at 5 years. And this is our initial results of carbon beam irradiation systems. We have so far completed, yes, after 6 months of opening, we have finished 24 HCC patients. And we have now completed 50 cases, and the most old patients are 89 years old. And this is our result of responses. Still number is very small, but it will increase because we have almost 60 to 70 HCC cases per year. Response rate is almost, disease control, CR, PR, SD is almost 100%. So it's a good controlling bullet for us. And the apparatus doesn't affect to the liver preservation or liver function test. And tumor markers in general is decreasing. Let me show our most significant and dramatical cases. This gentleman, 70 years gentleman, diagnosed as NASH at 2019. He found diagnosed as a multiple HCC at 2020 November. So this CT scan shows the bilobar spread of HCCs. So as a daily practice, we gave them immune combo as a first line, and actually several tumor markers are improved, but AFP is still remaining, and actually CT scan shows the remaining arriving SCCs in both lobule of the liver. So we aim to give him a second shot, second bullet. And this invasive tumor, large tumor in S6, we gave irradiations. And the remaining small portions, we are ablated him. This is his clinical course. After irradiation and ablations, his tumor marker completely normalized, and he is now cancer-free. And so we are conducting multi-bullet and multi-system, a multidisciplinary approach to curing HCC now in our daily practice. So this is the reality of silver bullet. Silver bullet is, as I told this morning, it's a mice in Europe. It can kill the vampire or monster, but actually, silver bullet is not silver. This is a real experiment. In some American TV show, give some actual scientific experiment, and then they demonstrate that then silver bullet is less accurate than red bullet, and silver bullet was slower than red bullet. So it's as a real weapon, they are not strong enough. So we need to combat with HCC with multidisciplinary, and still my conclusion is we are in the middle of the quest journey. So unfortunately, there is no single magic silver bullet in the real world. Only the combination of every available means will help us to find the narrow way to cure our patients with HCC. So again, multidisciplinary approach seems to be feasible so far. So our mission complete, and I'd like to share our colleague and our great friend as a hepatologist. Thank you very much.
Thank you very much. How many years you graduated medical school? 1989.
89, yes.
Yes.
No, 87.
87.
Yes.
So that's almost 36 years.
Yes.
Yes. Congratulations. And,
well, thank you very much.
I like your characters. So maybe the people here in Yamagata also like you. And then please contribute for the sake of your universities as a dean for next several years. And then maybe I pray for your health and also all the family members. Congratulations.
Thank you very much. It's very warm work. And I'd like to thank you for my colleague, especially for the colleague from the Yamagata University. Their number is a bit small, but their endeavor, and they are very hard worker to make this conference. Thank you very much.
Thank you very much, Chair and Lecturer.